Thank you. So I'll start with these are little unusual cases, and definitely I'll ask her to Nawaz sir to comment on it and the chairpersons. So we got this pediatric liver transplant. She's a 9-month old female child, Indian. Biliary atresia. It was missed Kasai. So she was referred to transplant to our center, and because of progressive deepening of jaundice, and she developed portal hypertension. And she came to us for transplantation on 13 December 2021. She underwent transplantation. You can see the typical biliary fibrosis, biliary cirrhosis, and also the micronodular liver, cirrhotic uh, liver. So she developed a graft dysfunction on day 6. So you see the bilirubin is high, 4.4. Direct is 3.6. ALT, ST also 464, 262. Gamma GT also raised. Platelet are okay. So in our centers, if any dysfunction is there in the transplant, they will do a biopsy. Without biopsy, they don't take any decision to pulse. So this is the core. You can see this is the linear core liver tissue, definitely blue area. So definitely a lot of inflammation is there in the portal areas. Lobule looks okay, looks largely pink. So if you see the portal tracts, definitely you see a lot of inflammation, mononuclear inflammation, suggesting that we are dealing with the T cell mediated rejection, in which you can see lymphocytes, histiocytes, activated lymphocytes, eosinophils. There is ductulitis also. You can see the infiltration of the duct here, infiltration by the lymphocytes, polymorphs, as well as eosinophils. And there is evidence of venulitis also. So the whole triad is there. You have inflammation, which is quite a severe inflammation in the portal area, and you have duct infiltration and the portal venulitis. But apart from that, if you actually look, definitely the smaller portal vessels, which are in the periphery or the inlet venules, you can say they're little dilated, and you can see rare mononuclear cells inside it. You can see in severe rejection sometimes, but this was the finding which was noted when the biopsy was done, and that when we reported in the evening that there's dilation. Another portal tract, again, you can see venulitis, inflammation is there. So TCMR features are there. And you can see these again, these vessels in the portal periphery, smaller portal vessels. You can see some mononuclear cells. However, this actually looks like stub. This looks like there is venulitis, and this kind of forming, these lymphocytes are just stuffing this. You can see the activated endothelial cells, and they are filling the this one in this portal vasculature. Again here, these are the portal area. So all the portal tract shows there is some kind of there are features of TCMR, but apart from that, if you see these kind of portal vasculature here, they are showing a lot of these cells inside. So there is some kind of capillaritis which you see in the renals. We are seeing these features, and you can see. So there's endothelitis, which is a typical endothelitis of TCMR, as well as which is now called as microvasculitis. We thought that we are dealing with some kind of microvasculitis also. Here, what you see, this is very typical actually. If you see this portal vessel here, you can see these endothelial cells are enlarged, and there is cytoplasm. Then generally, you will not see any cytoplasm in the endothelial cells. You see these cells embedded in it. So this is typical, this kind of forming a thrombi here, just obliterating the lumen, partial obliteration here. And again here, you can see the activation, endothelial cells are activated, they are enlarged. You can see some cytoplasm, the inlet venules also dilation, and some cells also, apart from the typical features. Here you can see the eosinophils also causing infiltration of the duct. There is cholestasis. You can see the bile here. There is typical central venulitis also, cholestasis, and there are areas of necrosis, patchy focal necrosis. Also, you can see a apototic body here. So there is lobular injury also near the central vein, central lobular injury, and severe portal inflammation. So definitely we are dealing with severe TCMR. That's the thing. But was there microvasculitis? Because it was severe TCMR, and when severe TCMR, you have endothelial disruption, which can actually lead to cells inside the lumen. So were we dealing with with associated AMR is also there, because bilirubin is high, bilibili is high, enzymes are also quietly raised. So we always, whenever severe TCMR is there in our center, we have the thing to do the C4D next day. This is the evening report. Next day, we performed the C4D, and it kind of came granular positivity in the portal vessels, more than 50% of the circumference. C4D in the portal vessels can be on the basal aspect or on the luminal aspects. Everything is considered positive, and you see these portal vessels here. Other portal vessels also, again, definitely positivity. Majority of the portal area, more than 50%, shows more than 50% of the circumference, with typical granular positivity of the C4D. Also, you can see C4D will highlight the necrotic hepatocyte, so it is positive also here. Sinusoidal also, it was some areas shows very strong granular kind of sinusoidal positivity in this one. So we thought that that severe rejection is there, and this is a mixed rejection. The TCMR, because C4D has come positive, so we suggested this is, and we immediately that day, the next day, we advised we should do anti-HLA or DSA antibody. Workup was suggested, but in clinical, in liver side, they generally don't believe that AMR cause dysfunction. They know that AMR can occur, but to think of it will cause a liver dysfunction, they generally, so they will usually treat with TCMR first, like, and they should do like that because AMR is extremely rare in liver. So treated with 5 doses of typical what they deal with severe rejection. Tacrolimus dose was optimized for the start, but 5 days rejection was, there was no improvement. Now you see the ALT 795, AST 745, Billy is 4.45, platelets are decreased. So there is some evidence of now, looks like probably thrombi is there, some AMR is there, platelets have decreased. DSA done on 14th post-operative day, when I again requested, no, we need to do because it's steroid resistant. And then whenever steroid resistant, they will do. So HLA1, mild positive, 1410, HLA 1564. So both are positive. We don't do pre-donor because of the cost issues. We never do the pre-transplant DSL. So these, we don't know if they are de novo or pre or came or was already there. So, but there was no issue of transfusion or any surgery in the patient. So repeat liver biopsy was done. So now this is mostly pink biopsy. Actually, you see the blue thing is gone down because they have treated with steroids. So now the inflammation is reduced. We expect because steroids again. So TCMR factor, which was there in the graft, has actually reduced. But you see the microvasculitis, the enlargement of the endothelial cells, the mononuclear cells in the capillaries is still there, and a lot of dilation in the portal vasculature as well as inlet venules. And also there is more injury in the lobule, also showing injury with cholestasis. Congestion is also there. Here again, actually most of the portal area, they are not expanded here as such, but you can see the activation of the endothelial cells and also mononuclear cell inside it, and some meningitis still there. Again, here you can see the kind of cells are there. So in this biopsy also, we said definitely now features of because C4D HLA has come, even if it's low, and all this positivity we are dealing with. And in the central area again, there is evidence of necrosis, congestion, cholestasis, and also this kind of hobnaling or activation of foam cells also, because cholestasis was persistent. We start seeing foam cells also in the lobule. C4D again now stronger actually. So C4D, it was just more than 50% of the circumference. Now actually overall 90 to 100% of the vessels, of the portal vessels, were positive throughout. So AMR, final impression was us, we are definitely be leaning with AMR, which is still rare, but it can occur. DSA was repeated. I asked them that we should repeat and see if the level is going up, because everything is going up. So now levels are increased. You see the class 2 level more than 10,000. Now this is very significant. More than 10,000 class 2, definitely because there is upregulation. Now there is more injury to the liver, and that is leading cause of. So now treated with plasma exchange was started. 2 doses of IVIG also given as per unit protocol, and there's also a consensus thing. There is no as such guideline how to treat liver with AMR. Sometimes they just respond to steroid also. Following the treatment, bilirubin showed improving trend. It's start reducing, and we again repeated the DSA, and HLA now is reduced. So HLA reduced, so third time. So we thought definitely the treatment has worked with this symptoms also, because this clinical dysfunction also reduced and HLA levels also reduced. So at the discharge in 2022, Billy was 1.6, direct 1.2. It's still a little deranged is there, but after that now we have, I think, up to 10 months follow-up. We were recently working on our pediatric transplant paper, in which we identified this is 10-month now follow-up is available, and she's okay. Enzymes are around 60, 70, Billy's 1.2, all those things. Platelets are also adequate. So those treatment has worked, but she is on, because of this, has been on follow-up. It's 8 months, but now it's 10 months of the follow-up is available with us. So AMR in AVO compatible, sorry, I didn't, this was an AVO compatible graft. AVO incompatible are less common. So this is very rare. 1% in our center out of 700 pediatric liver transplant, we identified 210 dysfunction biopsies were there. Total 5 we have identified with features of histology, C4D, clinical dysfunction, and DSA positivity. So 5, so around 2.5% of the graft shows AMR, and 3 developed refractory. So it's actually very severe disease and need to be picked up early on. Can contribute to early. Actually, the Pittsburgh and Baylor data suggests that 10% of the early graft losses because of this injury. And liver is a very immunoprivileged organ. There are various reasons to it. That's why AMR the clinician don't consider. Actually, earlier I work with Professor Ella. They actually used to do in King's when you have a lot of hypersensitization with kidney or heart, they used to do liver along with that, so that liver can take up the burnt and kidney can be can function well. So two-hit hypothesis has been proposed because HLA2 is it's very new. It's not seen only in dendritic cells or cover cells in the graft. So there's upregulation. That's why it happened to it. So you have rejection like or infection which will upregulate HLA2, and that leads to severe injury. Mostly persistent allograft dysfunction despite. So this is a very strong indication. If you see that and you excluded anything, except any other thing has been excluded, then you think that yeah, you might be dealing. Thrombocytopenia can be there, hyperbilirubinemia, low complement. Complement was not done in our case. A DSA positivity here in our center more than 1,000%, but generally it would be more than 3,000 to 5,000. Very complex pathology, very difficult to actually identify. You have to look for it all the time to help the clinical colleagues. And donor specific again. If you are preformed, they generally go. You don't find them after the transplant, but class 2 persist or de novo class 2, they cause a lot of injury. Criteria has just been proposed in which all 4 criteria were fulfilled in the case: portal microvascular dilation, hypertrophy in mononuclear cells, serum DSA positivity, class 4, diffuse C4D, class 3 with more than 50% of the portal tract involved, and exclusion of ischemia, any infection or graft. And there is suspicions and intermediate criteria. Also, H score has been given usually up to 4 cells, 4 to 10, and more than 10 cells. But I think it's all clinical every time. Scores, it's like numbers game is in pathology. We always kind of see what's the clinical thing, and even if it's 2, it's not like that. It's not severe rejection. So you see the clinical picture and you suggest that probably we are dealing with severe AMR. Also, again, C4D will be no minimal C4D, focal and diffuse C4D. Also, these are one of our other case in which we saw typical microvasculitis. You can see the embedding, the kind of lot of mononuclear, more than 10, very severe microvasculitis. Most of the time in our all 5 cases, actually TCMR will be there. But the features of TCMR, is it TCMR is there or they are just AMR changing, mimicking the TCMR? We don't know, but features of TCMR, venulitis, ductulitis, you see inflammation also, and here also. So very severe capillaritis here you can see. Occlusion also in one of our case actually is kind of thrombi was found in AMR. You can see this mononuclear cells inside and including the vein, and a lot of necrosis extreme. Actually, we lost this patient within a month. There's DSA positive severe injury. And this is again just to show you what is typical. This is one of our first case in 2014 in which we identified the typical activation. You see the portal vein here. They are kind of so much activation, hormonating of the cells, and they are kind of embedded in it. This was also DSA positive. So when you see these kind of features, we can think of that probably we are dealing with AMR like insult to the liver. So VOD, microvasculitis, and arthritis also. This is one of the case in which we see a lot of eosinophils and severe arthritis also. So when you see arthritis, you should think of AMR in the liver also. So this was the first case.
Yes, that's a very nice case. And I think many of the surgeons who say ABMR does not exist in the liver is because it's rare. Most people have small programs. They have to live 10 or 15 or 20 years before they will see one. Whereas a large center like you has been able to see it, after a few years. So we've also been through this phase of trying to convince surgeons that yes, ABMR occurs in the liver, in the lung, in the heart. They are everywhere. So I wanted to ask you whether you have some cases in the ABO incompatible ones, and is that pathology and different, especially the C4D?
Sir, in that C4D actually become very strong. We recently actually presented our data in last year ITS, 20 cases of pediatric ABO incompatible and excellent survival. All have survived more than 1 year. And we saw few cases, 2 or 3 cases only, because they should so much pretreatment, sir. Titers will always be 1/4, 1/8, so very difficult to see. In which we thought actually when there is rebound increase in titer, few cases which we have seen, and then actually enzymes were not deranged, but they saw 1:64 and 1:32, and again it increased to 1:128, even after all the absorption, everything. Then they did the biopsy, and then biopsy I showed a lot of necrosis actually was there. Mm-hmm. Severe necrosis and a lot of microvasculitis. I saw some microvasculitis, a lot of cholestasis, necrosis, a lot of hemorrhage in the biopsy, and then C40 was very strong. So perisinusoidal kind of all the inlet venues, everything like this one. Generally in ABO it comes, but it is not as strong what I have seen in ABO incompatible.
No, my question is, in the kidney transplant world, they say that C4D positivity per se shouldn't be used to make a diagnosis because it can be
Yes,
accommodation.
yes.
So what is, because I don't see these. So what is your
So
experience?
because of necrosis, when we see typical features, some and necrosis is also there, ductal reaction, cholestasis, titers are increased, and then liver dysfunction starts. When when they did the biopsy, they went and did the biopsy, and I say no, I think we are dealing with AMR because titers are high. Sir, one is C40 will come always positive because you have always you can't have zero. You will have at least 1:1 or 1 something would be there always. Some complement activation will be there in deposition, but with clinical context and the injury in the fibrosis, and then they treated with that one also with all the they in that patient I remember they gave rituximab and plasmapheresis and adsorption everything and recovered. Actually that case we published that how the pathology actually pointed out first they thought maybe titer high but it's not causing anything, but somehow they did the biopsy and we got ultimately actually they have to do splenectomy in that case.
So talking of the ABO incompatible ones, do you do C4D on every biopsy or only when?
So ABO compatible, ABO incompatible, sir. If there is nothing, I don't do because if titers are not raised, C4D will come positive. That will really raise.
Oh, I see. So in other words, you already have the experience that if you stay in a series of, let's say, 50 biopsies with ABO, most of them will be C4D positive.
C4D comes all.
They're always positive.
Yes,
that's what I wanted to ask.
Two titer C4D will come, but that is not significant. It will confuse people because any C4D now I say they start thinking because they have lost some patients. They think, oh, this is very significant. But in incompatible, I say don't think. You have to see for clinical dysfunction, biopsy injury, rather than just focusing on what pathology is.
Okay. And so the other comment I wanted to make is, and you already made it, that most ABMR is mixed.
Yes.
So even when you're showing those capillaritis, if you do the immunohistochemistry, they will be maybe 2/3 macrophages, 1/3 T cells. So even if something is being called ABMR, there is a substantial T cell component to it. And we really don't have any good drugs for ABMR. So most of these people should get initial treatment of DCMR, even if we are calling it ABMR, because most ABMR is mixed.
No, because I have no experience. That C4D positivity criteria. So if you draw a parallel from the renal world, then linear, staining is important. What you have shown is mostly granular sort of staining. So is that applicable even in the liver? Linear. What is linear granular? Means like it is circumferential and granular. Matlab, yeah.
So I would like to say that this linearity and granularity is in the eyes of the beholder.
Okay.
I have actually sat across the microscope with people and I was saying, this looks a little granular to me. He was saying, no, this is linear.
Yeah, very true.
And I think the immunoperoxidase, actually the immunoperoxidase does develop in a granular fashion. So even though the fluorescence is really bright and green and linear, on the immunoperoxidase, actually, in my opinion, granularity is more common and shouldn't dissuade you from making the diagnosis, but it should be convincing. It should be circumferential and definite. Granularity a little bit doesn't matter.
Nice presentation. And as you said that one should consider antibody mediated rejection since it's so rare when it's not responding to treatment, isn't it? But by the time damage would have already occurred, like in renal transplant, there is occurrence of transplant glomerulopathy or PTC lamination as a chronic damage by ABMR. So what is the counterpart in liver? And to avoid that, is there a case for doing C4D upfront in all these biopsies? Because see, the point is we don't want to have a permanent damage. And C4D is something which is very affordable, I would say. If you compare your cost of liver transplant and then you don't want it to be injured. So what's the status of chronic ABMR, and is there a recommendation for using C4D upfront to kind of pick it earlier? Because the parameters which will pick up ABMR are too vague in a setting when already a transplant has been done, isn't it?
Second.
So early diagnosis of ABMR is a very desirable goal, but you can also diagnose it too early. So the studies you are suggesting should be done, but if you do those studies, Don't start treating everybody who has C4D positive. So that will be a research study. You do the C4D and you'll see a whole spectrum of changes. And then you have to decide, what do I treat? What do I not treat? So it's a worthwhile project, but a scientific project, and the molecular takes it to a different level. They can detect it even earlier, but you can't start giving plasmapheresis and rituximab to everybody. So you have to judge the clinically actionable threshold. And so your study is worth doing as long as you don't start over treating. No, because it's so rare. People don't have a chance to study it. They don't do the DSA. Even our surgeons, we have to push them to do DSA. DSAs are not done by liver surgeons. And the C4D in the liver is not as reliable in terms of specificity and sensitivity as it is in the kidney. So these are the difficulties of advancing this subject. So, yeah. So that's an epidemiological observation. In other words, if you take cases of well-known antibody-mediated rejection, they will have more stromal positivity than people who do not have antibody-mediated rejection. So if the capillaries are damaged by ABMR, you would expect the C4D to leak and get into the stroma. But it cannot be used as a diagnostic test in individual cases. So the diagnosis of ABMR in individual cases has to be on a combination of the clinical picture C4D and DSA. And if the DSA is only stromal, you can use it to support it. But of course, it can be non-specific. Yes.
And
we do HLA basically for medical legal purpose. It's just to submit to the committee. It's a low HLA BDR. We do just low resolution. Don't do high resolution to really look for, because actually to believe that AMR is still, I think it will take 5-10 years more to when at least 100 cases will overall come from all centers and
And I can mention that if you biopsy long-standing livers, 5 years, 10 years out, many of them have DSA, many of them have C4D. So is that a very mild form of ABMR? Yes. But do you need to treat it? No. So the more you learn about a subject, the more you learn about the lower end of the spectrum. In the 90s, even in the kidney, in 1990, the only antibody rejection we knew was hyperacute. Then we saw acute, then we saw subacute, then we saw chronic. So the same happened with C4D. Initially, we were only calling more than 50% capillaries positive. Then it became 10 to 50. Now it's 1 to 10. So the more you study a subject, the more you realize there are mild cases. And then you have to decide which ones to intervene and where not to intervene.
Second case, I hope I have time. So this is another 60-year-old male patient and no comorbidities. 2019, he was evaluated for jaundice, swelling of lower limbs, fatigue was there for 2 months, Billy 32, ALT, ST 98.98 and 55, ALP, GGT slightly raised, albumin 3, INR, viral serology negative, ANA 1:1:80, IgG elevated. Immediately clinicians thought that are we dealing with autoimmune hepatitis. Varices were there. So there is evidence of chronic liver disease in the patient. Portal hypertensive features are there. CECT, they said cirrhosis is there, nodular liver, cirrhosis is there. Yeah, varices are there, all typical features of cirrhosis, cryptogenic or autoimmune, they don't know because male patient. Ascites, splenomegaly, no SOL, and patent hepatic vein, portal vein, no other, any injury or anything was detected. Decompensated CLD was the diagnosis. Etiology, possible AIH, and Mendes 33, child C, portal hypertension. So underwent LDLT at our center, 2019. So this is also actually will go on. 2019 underwent, extubated on post-operative day 1, removed PD3, all those things are done, everything. Discharge on post-operative day 10 with immunosuppression. So on the discharge, you can see LFT, bilirubin little high. Sometimes they take little time to settle, to 15 days, 20 up to a month. So they settled down. This was the explant actually, which was, so it is very micro, very cholestatic. Bilirubin was very high, very cholestatic, but very micronodular liver. It will look like that we are probably dealing, is this micronodular cirrhosis we are dealing with this patient, because ANA stream, maybe this is a mixed cholangiopathy, something which is ANA positive. So nodulity, but here you see actually it's nodule, but hardly any fibrosis. There's cholestasis, but there are a lot of these nodules without any obvious fibrosis. So what is this? So this was actually there was fibrosis was very limited only in the portal area. You can see this portal area. Portal vein also appear to be little thickened. Here is central vein. They are kind of very narrowed in the very approximated central vein and the portal area here. Some injury is happening. Some ductal reaction. A lot of congestion is happening. Again, portal area. So hardly you see any fibrosis actually. Just very minimal fibrosis happening in the portal area. Here again, a lot of cholestasis, congestion, some inflammation here, central veins here, some fibrous septa coming out through it. Here again, approximation of the portal area and central vein. And here is a pull tract in which actually you don't see a portal vein here, so just one herniation here. And here also some portal vein appear to be sclerosed here. This is okay. So again, what you see? So you have congestion and you have what? You have features of in the low power. If you see, so you were seeing these nodules. You were seeing these nodules. You see, go into just to you have in the periportal, you have these kind of regenerative nodules. So we obviously we are dealing with congestion is there in the periphery. We are dealing with nodular hyperplasia, and the portal area. You can see how portal vein how sclerosed is actually is this is an artery here, and you can see a portal vein here, very sclerosed portal vein here. And fibrotic portal tract. A lot of cholestasis is happening in the patient, intraclavicular by in the hepatocytes, and also there was bile lakes and some evidence of foam cells also. So we are dealing with reticulin. We did definitely not a regenerative hyperplasia is there. No obvious fibrosis, congestion is there, and all these features are there. So. Again, just to show you that definitely we are dealing with features of obliterated portal veinopathy. You can see this thickened portal vein here. Again, approximation, very fibrous portal tract, very extremely fibrous portal tract. And this also here, difficult to see a portal vein here. It's completely sclerosed actually, and extensively fibrous portal tract. Here again, you can't see. You can see a duct, you can see an artery, but no portal vein. So, but we are dealing with features of obliterated portal veinopathy and nodular hyperplasia approximation. So again, just to show you how intimal fibroplasia, you can see these the thickening of the intimal area. You can see the multiple smooth muscle layer also here. So definitely thickening of the wall, fibrosis. Again, just to show you a lot of vascularization, angiomatous transformation of the portal area also, all showing features of we are dealing with cases of NCPF only. Central veins were okay, no thrombi we could identify. Some fibrosis was appreciated, but no thrombi we could see. And there is congestion here. But that congestion is also actually a little unusual. You start seeing that there appear to be little cellularity here in these congested areas. This is just to show you trichome. There is some evidence of fibrosis approximation. Some septa you can see going here to there. Occasional, maybe I don't know. It's just stopped here. It's not even actually connecting. So there is kind of some fibrosis, which we know these kind of incomplete septa are known. So features were all there with extensive congestion on the biopsy. Again, crowding, fibrosis, or seen confirms that there is a lot of there are septa formation, occasional, complete, incomplete, and all those changes of probably chronic changes of NCPF. Hilar area, you see, no, nothing. Portal vein was obviously okay. No thrombi, nothing. So we excluded that hilum, there is nothing. All vessels are in the smaller and medium-sized portal vein. We suggested that probably we are dealing with NCPF. Again, congestion. Look at the congestion here. Now, congestion is it, but now you see in some areas, not whole, extensive grossing was done in this case. You start seeing some very atypical cell here actually. There appear to be crowding here, congestion. There is cell loss, hepatocytes are lost. You can see these cells here. They literally, you don't see mitosis. But some ATPI is there. They are displacing the hepatocytes. Again, here you can see these cells here. Sometimes they are what kind of cell are they? Histiocytes or the necrotic hepatocytes? What very difficult to actually appreciate, but definitely cellularity in the sinusoids area appear to be increased. Maybe they are kind of what kind of cells we need to know probably when we do IHC. We'll appreciate it better. Here again, here definitely some kind of multinucleation now starting. And you can see here also. Yes, definitely these kind of spindly cells, some ATP mild to moderate, no mitosis, but you can see these cells, they are kind of filling in the sinusoids and causing compression and injury to the liver parenchyma also. Here again, you're just forming actually a mass like. So we don't know, is this kind of hepatocytes which are compressed or histiocytes? Very sometimes extremely difficult to appreciate in this case what kind of cells, but then we did C34 in ERG because I suspected that probably we are dealing with the case of angiosarcoma with congestion, sinusoidal angiosarcoma in this case. So turned out C30 was actually much more positive than what you can actually see in the HE. HE we really have to look for it, and we did it just as a guess what we should do and find out. So turned out to be they were all positive for C34. Cells P53 also came. Generally moderate to strong staining we considered this as considered positive in angiosarcomas here in liver and elsewhere. So there was moderate to strong staining. A lot of cells were positive for P53. So suggesting there is P53 alteration, Ki67. Now, this actually proves the diagnosis. You can see extensive proliferation of the Ki67, which is usually not seen. These are not in hepatocytes. Hepatocytes were also because proliferation is there, but mostly those cells which were there positive, they all were more in some areas, most of them were positive for proliferation. ERG was positive, CME was negative in the case. So we identified that probably the acute failure which we were talking about decrease was actually, I think, incidentally hepatic angiosarcoma. It took them as a shock that how angiosarcoma, because radiology nobody commented anything, and that can be the case with sinusoidal angiosarcoma. It's a pathological diagnosis. You have to put it forward. Probably we are dealing with this case, and obliterated portal venopathy features not a region heavily. So it's kind of a thing that how you have sinusoidal injury and you have portal venopathy changes. So how to? So non-cirrhotic portal hypertension, CLD is there, which you can't diagnose when you have sinusoidal injury. But in this features, definitely CLD history is there, varices are there. So there is them. And in that case, we have developed an angiosarcoma, no evidence of cirrhosis presenting as ACLF. And then we published this case. So now he was discharged. He developed top neurotoxicity. It's changed to cyclosporine. So angiosarcoma can occur. Pathologist has to look for it. And in when it's congestion and can be very, very deceptive, these cases, and can be just diagnosed as deception. 2 months after follow-up, patient developed itching and worsening of the LFT. And this was explained to the patient that you have angiosarcoma. So you're bound, you don't, you got very poor prognosis, can recurrent also, everything explained. And patient 2 developed itching, developed an osmotic stricture, which was treated. Now he was okay. 2 years he was okay, followed up here and there, gain follow-up here in his city, everything was done. Presented as in April 2022. Now he has developed abdominal pain, jaundice, and itching again. So bilirubin is quite high. Again, ultrasound, dilated HBR, MRCP, dilated CBD, everything. We are again dealing with stricture again has happened. You have to do, you have to take out the previous stunt, do the restunting, everything. Cholangitis is there, everything is, that's the diagnosis. So they did that. They changed everything. They removed the stunt, replaced, but patient worsened. Nothing happened after the stunt change. Jaundice increased, abdominal distension, patient developed ascites. Vasculature normal, IGB dilated, no other. There is just this is all injury because of the stricture which has happened in the bile duct. Ascitic tapping was done, high SAR, LV albumin. Graft dysfunction. They did all the viral workup because biopsy is still not done. Biopsy because of the so much injury to the biopsy they avoided, because they have to do transjugular. So CMV, PCR very high, 11,000. It started on ganciclovir, jaundice increased. Chronic infection suspected. Now they did biopsy because nothing is happening. They have started for CMV, changed treatment, everything they have done, but there is no improvement of the patient, so did the biopsy. Now this is the biopsy. This is the core which we received after some time when nothing improved. And again, there is congestion. You can see this congestion in the liver. You can see extensive cell loss is also there in the biopsy. Portal tract again, okay. Duct is there, some injury, but portal tract okay. Some mild fibrosis, arterial, portal vein. Again, you can see this congestion is there in the liver. And here again, portal tract. So there is no chronic rejection. There is no other, there is no biliary obstruction, features of biliary obstruction, congestion. And again, if you look at those sinusoids, actually there is a recurrence of the tumor after 3 years, almost after 3 years. The patient developed recurrence of this case with such severe injury. All the areas very subtle, but increase in cellularity. And again, can you see again all these cells, they are kind of filling in the sinusoids, can be very deceptive, very difficult to actually pick up. So fibrosis, some fibrosis was appreciated. This is ERG, C34 again in the biopsy, very strongly positive. Ki67 again, P53 again positive. ATRX was kind of, we don't know if it comes or not. It's sometimes very difficult to actually report ATRX because hepatic, some of the hepatic are show loss. And CK7 again showing tubular metaplasia. So there was chronic obstructive injury, which CK7 showed. So congestion, malignant sinusoidal cells, vascular cells, angiosarcoma. CMB was done, HSV, in the biopsy, and HHV, everything was negative. So angiosarcoma, just a last slide on it. So no treatment available, generally 6 to 7 decades, but they can occur early. Recently, we saw a 20-year female presenting with sinusoidal angiosarcoma, which also underwent transplant for liver failure. So somehow you have to pick it up only after when they have done the transplant, which because it's a contraindication, and resection has no survival benefit, very poor actually. Mostly patient die within 6 months. This however survived, probably because of sinusoidal and no extra hepatic at that time was there, so he survived and developed recurrence. ATRX loss have been seen, and now fusion has also been reported. These are some some of the, just to put you, sinusoidal, these are hepatic angiosarcoma cases. This was a section done with spindle type whirling of the angiosarcoma. This is basoformative. This is very typical. This looks extremely beautiful in slide. Actually, you see very malignant cells here. This is basoformative angiosarcoma in the liver. This is pileotic type angiosarcoma. And this is the angiosarcoma in which definitely we appreciated ATRX loss. So the ATRX loss has been demonstrated earlier, and we have also shown that it's rare, but it can happen. And sinusoidal especially, you have to look of it, but just it should not be confused with hepatocyte angiosarcoma, which is also sinusoidal because of the matrix. It doesn't produce congestion. When you see hemorrhage, think of angiosarcoma rather than a case of meningoendothelioma. This is the one of our recent 20-year-old, actually multiple nodules were there, and you can see this, and this is also positive for CAMTA1. So generally 90% of the angiosarcomas in the liver will be CAMTA1. Rarely you can see TFE3 fusion also. So not to be confused with this, because this is for this transplant is the cure. Even they have outside, they have multifocal lesion, transplant helps them, they survive longer. Angiosarcoma is still, transplant is contraindicated because of the recurrence and all those issues with immunosuppression. Thank you.